Okay, I will do a short introduction and then we can start. So, hello everyone, and thank you for joining us for another seminar of philosophy and psychiatry here in Belgrade, in Serbia. And it is my pleasure and honor to introduce our today's guest, and that is Dr. Eisuke Sakakibara from Japan and University of Tokyo. I will just say a little bit about him. He's both an MD and PhD. So he graduated from the University of Tokyo and also got his doctorate from this university in 2018. The theme of his dissertation was measuring resting state functional connectivity using near infrared spectroscopy. He now works as a lecturer at the Department of Neuropsychiatry at the University of Tokyo. He has published papers on philosophy of language and philosophy of psychiatry, and he's currently running a study group named Philosophy and Psychiatry and Psychology, where philosophers, psychiatrists, and psychologists meet monthly to discuss fundamental issues in psychiatry and clinical psychology. That is just for a short biography of our lecturer. And today he will be talking about implicational injustice, a type of epistemic injustice that he has conceived, and will give an analysis of that. And so, Dr. Sakakibara, the floor is yours. Please.
Thank you for your detailed introduction. My name is Eisuke Sakakibara, and I'm from Japan. I met Stefan in this May in International Network of Philosophy and Psychiatry Conference. And he gave me this opportunity to make a presentation on my recent study. So I'm very happy to be here. So today, may I start? So today, I will talk about application of the notion of epistemic injustice to doctor-patient communication in medicine. So this is the overview of today's presentation. So today's topic is basically doctor-patient communication. And the quality of doctor-patient communication is essential to patient-centered care and shared decision-making. Effective healthcare communication can affect health outcomes through various pathways. For example, enhanced communication can improve socially disadvantaged individuals' access to healthcare. More effective care is facilitated as patients gain a better understanding of their conditions and as both the physician and patient develop a shared understanding of the situation. Good communication can strengthen the therapeutic alliance and increase patients' motivation for treatment. The clinician's empathic engagement helps patients cope with their emotions. Effective communication enables patients to obtain better support from their family and society. So collectively, these factors enhance patients' sense of agency, leading to improved clinical decision-making. So better a meta-analysis shows that a better doctor-patient communication is associated with reduced patient anxiety, improved quality of life, and enhanced treatment adherence. And a study also revealed that training physicians in communication skills contribute to better control of hypertension in patients. At the same time, doctor-patient communication has various problems and has been the subject of extensive research. One traditional framework for conceptualizing these problems is to view them as a collision of two discourses, which Mishra terms the voice of the life world and the voice of the medicine. So these two voices echo Kleinman's distinction between disease and illness. Illness is a subjective experience, embedded in patient life situation, encompassing changes in behavioral patterns and interpersonal relationships. In contrast, disease is the reconstruction of illness through medical theory as an anatomical or biological abnormality that is disconnected from its social context. So the problem is physician tends to avoid addressing patients' living situations and the emotional impact of the disease and tend to discourage them from expressing their concerns and expectations. Doctors focus exclusively on diagnostic and biomedical issues, while overlooking clues that hint at the patient's emotions and explanatory models for their symptoms. Doctor-patient encounters that addresses psychosocial issues are associated with higher patient satisfaction compared with those that concentrate on biomedical issues. So here appears the notion of epistemic injustice. The notion of epistemic injustice is proposed by Miranda Fricker. Epistemic injustice is a generic label for a person's status as an epistemic subject being wronged or disadvantaged. Epistemic injustice was initially developed to articulate the injustice experienced by women and ethnic minority. Recently, the concept of epistemic injustice has been applied to problems in a variety of other domains, including education, the judicial system, and healthcare. So Fricker indicated two kinds of epistemic injustice. One is testimonial injustice, which occurs when the hearer confers unfairly low credibility to the speaker's testimony because of the prejudice against the social groups the speaker belongs. For example, women or people of black skin, etc. And the second is hermeneutical injustice, which happens when the marginalized people have little conceptual resources to give meaning and voice to their experiences because they had been prevented from participating in epistemic exchange for a long period of time. But epistemic injustice is not limited to testimonial and hermeneutical injustice. So the epistemic injustice experienced by patients in the context of medicine and healthcare has been rigorously investigated. For example, patients sometimes experience testimonial injustice because of the prejudice that they are emotional or incapable of making rational judgments. This is especially true for patients whose complaints lack objective abnormalities, such as chronic pain and fatigue. Moreover, to avoid being perceived by physicians as difficult patients, patients often suppress complaints that do not align with physicians' expectations. This is categorized as testimonial smothering, a form of epistemic injustice proposed by Christy Dodson. In addition, even when patients are trusted as informants, they are frequently excluded from participating in clinical decision-making because physicians have a monopoly on determining what information is medically important. Among the various issues, special attention must be paid to epistemic injustice in psychiatry because of the prevalent stigma against mental illness and the potential cognitive impairments associated with mental disorders. So the concept of epistemic injustice provides a theoretical framework for considering the ethics of communication and is useful for formulating problems in doctor-patient communication. So in this presentation, I will propose the concept of implicational injustice as a new subtype of epistemic injustice and show that it is frequently found in doctor-patient communication. So this presentation is based on my manuscript now under review in a philosophical journal. So preprint is available from the link below. So if you are interested, please visit the site. So let's see what is implicature and how oversight of implicature occurs. So I explained the notion of implicature based on the theory of relevance established by linguists Spelbel and Wilson. An implicature is an assumption that is not explicitly stated, but is implicit in the utterance of the speaker. So for example, as in the figure below, let Mary and Tom, a married couple, working together. One day, Mary said to Tom, I heard the cake shop in front of the station has just started to sell a new tart cake. I love tarts. Assuming that it was Mary's birthday, Mary implied that she wanted him to buy her a tart cake. So Spelber and Wilson, this is an example of implicature. So Spelber and Wilson formulated that the implicatures of an utterance are contextual premises and contextual implications that are mutually manifest to make the utterance relevant. So this is a delicate definition, but I'll show examples. So contextual assumptions in these examples are today is Mary's birthday, and people buy cakes to celebrate friends or family members' birthday, and birthday wishes should be sent spontaneously, and people who are given their favorite food will be happy, etc. These are assumptions. And contextual implications are, in this context is, if Tom buys a tart cake today, it will be Mary's birthday celebration. And if Tom buys a tart cake today, Mary will be happy, etc. So these contextual assumptions and implications are implicatures in this context. So, but implicatures can be overlooked because they are not explicitly stated by the speaker. Among the causes of the oversight of implicature, I focus on premature termination and informational inequality. So premature termination happens when the hearer overlooks the implicature because they do not explore the implicature of the speaker's utterance with sufficient cognitive effort. For example, Tom may not have enough time to think about the meaning behind Mary's word because he's too busy or too tired. Or Tom might have the preconception that the Mary is a woman who shares news about food for no particular reason. By contrast, informational inequality causes the hearer to fail elicit the contextual implication that the speaker has assumed because the hearer does not know or does not immediately come up with the information that the speaker takes for granted. For example, if Tom does not know or has forgotten that today is Mary's birthday, he cannot reach the implicature Mary intended to convey. So note that oversight of implicature differs from intentional disregard of implicature, where the hearer intentionally ignores implicatures. Because when the implicature was intentionally ignored, the hearer recognized there is the implicature and there is no communication failure. And the hearer is aware of the speaker's epistemic capacity. So there is the difference. And I also want to mention the notion of weak implicature. So there is a gradation of implicatures from strong implicatures that has definite content to weak implicatures that only have the power to determine the general direction of the conversation. When Tom is asked, "Did you ride your bicycle to the office today?" And if he answers, "Well, it was raining in the morning," there is a strong implicature that he commuted to the office by a means other than a bicycle on that day. An example of weak implicature is found when Tom speaks to Mary. "There is a blue bird in the tree over there," when they are out hiking in the mountains together. Although it is unlikely that this statement contains an implicatures of definite content, it does not mean that no implicature exists at all, because Tom's utterance has a broad and indeterminate implicatures, such as Tom wants to know the name of the bird, Tom wants to share the excitement of finding a beautiful bird with Mary, or Tom wants to stop the conversation and listen to the bird with Mary, etc. So statements accompanied by weak implicatures are very common in everyday conversation. So let's see some examples of oversight of implicatures in doctor-patient communication. So based on the recorded doctor-patient interactions, Mishra defined an unremarkable interview as a combination of three elements: the physician's question, the patient's reply, and the physician's subsequent question that serves to change topics. So as in the figure in the left, doctor's question, patient's answer, doctor's next question, patient's next answer, doctor's next question in the sequence is what Mishra called unremarkable interview. So in unremarkable interview, there is often no special implicature in the patient's answer other than they wanted to respond to doctor's questions. Special implicatures related to patient's life world are typically included in the utterances that deviate from this sequence. So I classify the deviation from unremarkable interview into the cases of patient-initiated assertions and cases of question from the patient. So this is a fictional example of oversight of implicature associated with patient's assertions. So context: a female patient with heavy alcohol consumption, elevated liver enzyme levels, and obesity visits a consultation room. So patient: I was told not to drink too much, but I still drink during half the week. However, I did not drink at all throughout last weekend. And doctor: I see that drinking a half a week places a lot of strain on the liver. So let's try to cut this back a little further. So interpretation: given that the patient had previously been a weekend drinker, the patient's utterance has implicatures. There has been a change toward improving my drinking habits, and I am making an effort to change my lifestyle. So the patient wanted the physician to praise her or share her attainment. However, the physician was so focusing on the negative aspect of patient's condition, he missed a sign of positive change. So this is a fictional example of oversight of implicature associated with patient's questions. Context: an elderly male patient visited the clinic to address his anxiety disorder. This occurred immediately after he told the physician that his anxiety symptoms persisted and that he had difficulty going outside. Further, he confided that he asked his son to bring him to the clinic. So, doctor, is there anything else you would like to discuss? Patient, doc, should I still stay on meds? Doctor, well, because you are still experiencing anxiety symptoms, I think that stopping the medication could worsen the symptoms. Patient, I see, I understand. So, interpretation. Given that this question was made just after he told the doctor that he was having difficulty going to the clinic by himself and he needed his son's help to visit the clinic. Should I still stay on meds? Implied. Should I continue to cause inconvenience for my son? If the doctor had noticed the patient's implicature and discussed whether the interval between visits should be widened, or whether the patient was being maltreated by his son, the visit would have been more fruitful. So these two examples are a fictional case, but this is an actual example. So this is an actual example of oversight implicature extracted from the study done by Levinson 2000. So physician, here, what's keeping you awake? Patient, I don't know. I'm not worrying about anything. Things are going pretty well. Casey taking wonderful care of me. I just frankly want to die. Physician, well, I don't think we can arrange that. Patient, no. Physician, aha, haha. Patient, I realize that. Physician, yeah, that's good, yeah. Patient, but I'm so discouraged and so desperate. So in this passage, the patient is expressing suicidal thought and needs psychological care. However, the physician callously stated that there was nothing he could do and rejected the patient's request for help. The patient's self-disclosure that he wanted to die was accompanied by a weak implicature that he wanted his feeling to be heard. So overlooking this implicature, the physician exacerbated the patient's despair and increased his risk of suicide. So let's move on to the notion of implicational injustice. Fricker stressed that some cases where the hearer underestimates the speaker's credibility and refuses to accept the true testimony are innocent mistakes and could not be categorized as epistemic injustice. So similarly, the oversight of implicature in physician-patient communication listed in the previous section does not necessarily fall into the category of epistemic injustice. An oversight of implicature is counted as epistemic injustice only if it stems from the hearer's prejudice against the speaker or unjustified ignorance of the speaker. In other words, an oversight of implicature is an implicational injustice only if the epistemic wrong of the speaker's misconception or ignorance of the hearer is derived from moral wrong. So implicational injustice is defined as follows. So it refers to cases in which an oversight of implicature is caused by the following one of two conditions. So condition one is the hearer's prejudiced underestimation of the speaker's sense of relevance. And condition two is the hearer's morally objectionable ignorance about the speaker. So let's see each condition in detail. So a low estimate of the speaker's sense of relevance arises when listening to a young child. In contrast, an oversight of implicature that results from treating the speaker as a childish or immature based on a prejudice against the identity to which the speaker belongs can be considered implicational injustice. So physicians are often more educated than their patients and often believe that their patients have inferior cognitive capacity. So it is true that with regard to medical knowledge, physicians have an overwhelming advantage over their patients. However, with regard to non-medical knowledge, the physician's epistemic advantage is not always maintained. So thus, the prejudice that patients have a generally low sense of relevance is a hotbed of epistemic injustice. So in relation to this topic, physicians often believe that patients always talk about irrelevant things. However, some of the cases that physicians have dismissed as irrelevant involve patients making statements that are relevant from a non-medical perspective. In particular, implicature about the patient's life, emotional landscape may be systematically overlooked. The second condition is morally objectionable ignorance about the speaker. So it is doubtful that there is a general moral imperative that one must know something about another. But when there is a longitudinal relationship between speaker and hearer, there are cases in which ignorance is not merely an epistemic wrong, but also a moral wrong. For example, there is no general moral imperative that one person must know another person's birthday. But if one person fails to remember their spouse's birthday, it cannot be considered merely epistemic wrong. So in a friendship or marital relationship, extreme ignorance of the other person is considered a lack of respect. Ignorance can also be a moral wrong when there is a responsibility on the hearer to know the speaker because of the hearer's professional role. The relationship between the physician and their patient is a typical relationship in which such a duty exists. The physician strives to know his patient's medical condition. However, the physician is often indifferent to the cultural, social, economical, and life background of the patient, and which could lead to oversight of implicature. So there are some notes on the notion of implicational injustice. First, any of the examples in the previous section could potentially constitute a case of implicational injustice. Conversely, the same instance could also be interpreted as intentional neglect or accidental oversight of implicature. It is impossible to pinpoint a single occasion as an unequivocal case of implicational injustice. Implicational injustice is recognized only when the oversight of implicature occurs repeatedly within a prolonged relationship and is attributable to morally objectionable faults on the part of the hearer. Second, structural factors within medical institutions and healthcare systems may contribute to the oversight of patients' implicature. For example, physicians' time constraints hinders the quality of doctor-patient communication. So if they lead to the oversight of implicature, the medical institution or healthcare system as a whole, not each staff in it, is the perpetrator of epistemic injustice. Third, the harm of implicational injustice especially afflicts the underprivileged people because it is more disadvantageous for them to conflict with the socially privileged people by explicitly stating something. So physicians in contrast, hold a dominant position compared to the patient, and they are more likely to communicate explicitly rather than using implicatures. So implicational injustice is problematic, especially for patients and not physicians. So in the last section, I compare implicational injustice with other types of epistemic injustice. So Fricker addressed the epistemic injustice associated with testimony and assertive speech act. Spivak pointed out that similar problems arise in other kinds of speech acts, such as commands, promises, and apologies, and so on, and proposed an umbrella concept of conversational injustice, which includes testimonial injustice. For example, unjustified underestimation of a speaker's epistemic capacities can lead not only to the hearers not believing a testimony, but also to the hearers not trusting the promise of the speaker. So implicational injustice and conversational injustice are logically independent concepts. So logically independent means implicational injustice can arise when the speaker is worthy of trust and what he or she explicitly says is accepted as true. Conversely, the conversational injustice may occur without causing implicational injustice. So I'll show an example. So if a person who believes that foreign workers are untrustworthy is told by a male foreign worker that he had dropped his wallet, the hearer may not believe this assertion, but may correctly infer that he wants financial assistance, which is implicature. So there is testimonial injustice, but there is no implicational injustice in this case. So second, even if the speaker's credibility has been appropriately assessed and the statement is recognized as truthful, the speaker may still be prevented from participating in epistemic collaboration. With regard to this, Christopher Fuquay presented an example of a student who attended a philosophical discussion, asks the philosophical teacher a question, and the teacher sees it as simply a question seeking factual information and does not recognize it as a question relevant to deep philosophical insight. Fuquay points out that people's epistemic exchange is not limited to the exchange of information, and epistemic injustice should be reframed from participant perspective, as he called it. And epistemic injustice proposed by Fuquay is later called participatory injustice. So rather than being a new category of epistemic injustice, participatory injustice is a unifying framework for explaining various types of epistemic injustice. So epistemic injustice experienced by the student, exemplified by Fuquay, can be considered an instance of oversight of implicature. So the teacher overlooked the implicature contained in the student's question that goes like, there are philosophical points that should be carefully examined. So implicational injustice is a type of epistemic injustice from the participant perspective. And the third, Hornsby and Langton developed the concept of illocutionary silencing to explain how, due to the dissemination of pornography, a woman's statement, no, is not perceived by the man as an illocutionary act of refusal of having sexual intercourse and results in sexual offense. Searle pointed out that there are direct and indirect types of speech acts. So direct speech acts are explicitly performed by an utterance. In contrast, indirect speech acts are performed by the speakers meaning more than what they directly stated. For example, could you take the thought is an utterance that directly questions about hearer's ability, but it indirectly requests for the hearer to take the thought. So it's directly questions, but indirectly requests. Some implicature in the utterance can be viewed as an indirect speech act. For this reason, part of the implicational injustice is considered as silencing of indirect speech acts. However, in cases of implicational injustice, whereas weak implicature is overlooked, it is difficult to interpret the overlooked implicature as some specific indirect speech act. Therefore, implicational injustice cannot be reduced to the silencing of indirect speech acts. And final contrast is Pitt's interpretive injustice. The interpretive injustice is a phenomenon in which a hearer perverts the meaning of the speaker's statement due to a prejudice against the social attributes of the speaker. For example, when Amaya, which is an example proposed by Pitts, when Amaya, the female manager of a restaurant, said, "I need a man," she simply meant that she needed a man to staff the hall. But the chef, who had a strong notion of male superiority over female, misunderstood her speech as implicating Amaya needed managerial support from a man with strong leadership skills. However, misinterpretations are not caused by prejudice against the speaker's social attributes, but by a prejudice against the content of what is being said. So for example, Tom, who has the prejudice that all foreign workers are dangerous, heard Mary said, "Foreign workers often have dinner at that restaurant." Mary only wanted to tell him that the restaurant offers authentic ethnic cuisine. But Tom misinterpreted this as a warning that the restaurant is dangerous and he should not enter the restaurant. So in that case, the point is that this misunderstanding is not constitute a case of epistemic injustice against Mary. So implicational injustice is a lack of interpretation of utterance, while interpretive injustice is a misinterpretation of an utterance. So they are very similar concept, but I think lack of interpretation is more directly linked to a prejudice against speaker's epistemic competence. So this is the conclusion. Adequate communication requires epistemic cooperation on the part of the hearer. So oversight of implicature occurs through premature termination of finding implicatures or informational inequality between speaker and hearer. Implicational injustice refers to an oversight of implicature that occurs because the hearer underestimates the speaker's sense of relevance due to some prejudice, or because the hearer is too ignorant about the speaker, breaching the norms of the interpersonal relationship between the two. Implicational injustice is a subtype of epistemic injustice from Fukue's participant perspective, but it has characteristic not found in other species of epistemic injustice. So in doctor-patient communication, patients frequently experience oversight of implicature and implicational injustice. So philosophical inquiries on epistemic injustice provides a theoretical framework for the ethics of medical communication, whereas medical communication studies has accumulated a wealth of empirical data on communication. So therefore, interdisciplinary research is beneficial to both fields. So this is to end my presentation. Thank you for your attention.
Okay, thank you. Thank you, Eisuke. This was excellent. Very interesting presentation, and I think that you gave a lot of very precise, very informative examples of this kind of implicational injustice and how it forms in the communication between with the patient. So I'm opening the discussion for questions and comments. So please, everyone. You can close the presentation if you want to. So are there any comments? That's okay.
Okay.
Anastasia, go on.
Good evening for you.
Good evening.
And thank you for your fascinating presentation. I'm not psychiatrist, only psychologist. Yeah, but still, like, I have in mind an example. What if when you spoke about the person who says about suicidal thoughts, yeah. What if I had such a case that it was malingering, that it was a fake? No, like the patient tried to manipulate me so that I would believe that he has suicidal thoughts and would show a lot of empathy, etc., etc., and maybe even more. I think in my case, I was also a teacher of psychology in university, and also this client wanted somehow maybe to influence because she had troubles with exams, etc. Yeah, with some other teachers, and yeah. So in the cases of malingering, like, can we apply your conception there? And yeah.
Thank you for your clarification. So in the case of malingering, what patient is saying is not true or exaggerated in a sense. And patients' utterance have implicatures that requires physicians to address in some way. So this is a kind of manipulation. So if the physician or healthcare professionals correctly identifies that this is a malingering, healthcare professionals need not respond to the implicatures made by the patient. So in that case, it is not implicational injustice, but I think it's a kind of intentional neglect of implicatures. But in the case proposed, I have mentioned, physicians don't uptake the implicatures or not recognize the implicature. So this is a oversight of implicature, and it may be a case of implicational injustice. So does it make sense? The difference between the case of my case and the case of malingering.
Yes, of course. Only still a big question how to detect when it's malingering or it's true.
Yeah, this is, I think, professional skill, experience is required to differentiate true testimony from malingering.
Thank you.
Welcome.
Okay, thank you both. And next is, I think, Pravaya. Go on.
Hi, thank you. Thank you for
Hi.
the insightful presentation. Hello. So my question was regarding, looking at this implicational injustice from an interpersonal lens, because I don't think that intersectional lens more than that, because I don't think that the experience is going to be same for everybody. Say the doctor-patient communication between a man and a woman is going to be slightly different, at least from my, experience here in India. Women are taken to be more talkative, more expressive generally. So doctors are even more, dismissive of their situations, conditions, whatever you might say. And then there could be a class, caste, and this is a question: could there be, you know, uh, a difference because of their identity, whether it be caste, class, or sexual orientation? So, could you please elaborate more on that?
Thank you very much. I think this is a very important point, and I understand your question is related to intersectionality.
Intersectional, yeah.
Intersectionality, and so doctors and the patients are different clusters, different member in a society, and at the same time, other category divide may exist between patients and doctors. For example, patients are female, doctors are male sometimes, or patients are ethnic minority and doctors belongs to ethnic majority and so on. In that case, I think implicational injustice is more prevalent because of the ignorance on the part of the doctors. And sometimes they underestimate the sense of relevance of the patients because of the attributes patients have. So intersectional issues worsens implicational injustice, I think.
Yeah, I feel the same because with my recent experience being diagnosed with depression and ADHD, that was something like which resonated with me because, when you say something, it could be taken in many different ways. But when the doctor is not, very quick on the uptake, it sort of gets swept away. So you might be trying to tell something indirectly, but it could not, or whether deliberately or indeliberately, is not understood by the doctor. And over a course of the process, I think it causes some epistemic harm to the patient. So that is why I wanted to bring about that question. Thank you very much.
Thank you very much.
Okay, thank you. Next is Rebecca.
Hi, thank you for really interesting talk and discussion. So you talked a little bit about how like pressures on healthcare systems, like lack of time for appointments, can mean that medical systems as a whole are sort of perpetrators of injustice. And I wondered if you had any views on what that implies for the sorts of duties on systems, because obviously, the medical systems, you'll know better than I'm not a clinician, they're operating with multiple duties and expectations on them to, you know, provide a certain quality of care, but also to provide care for, you know, as many as possible of the people who are seeking healthcare. So I just wondered if you had more to say, I guess, about what your conclusion, with which I agree, that medical systems can be perpetrators of this form of injustice, means for what we should be expecting, or what duties we should be expecting systems to respond to.
Okay, thank you. So medical system have to satisfy multiple purposes and conditions, and doing justice to the patient's epistemic status is only one thing to satisfy or protect. So other important goals is improving health status of patients and reduce medical expenses, or more just distribution of medical resources. So I think I agree that there are many requirements. So I think as a person, I think overemphasizing the injustice in this sense of medical practice is not doing justice to other purpose the medical system has. So I think there should be balance between multiple purposes.
Is it possible to say something, to come back and say something else on that? Is that all right?
Yes, of course.
Yeah, no, I have a lot of sympathy with that. In it, I just was thinking when you were giving your response that there's really interesting questions about the way in which implicational injustice plays into the way in which medical systems can fulfill these other requirements and these duties. Because in some of the examples you gave, you know, if the doctor in question was able to understand what the patient was trying to say, then, you know, perhaps over the longitudinal relationship, the patient's needs could be more neatly managed, I guess, such that, and as you said, like there's lots of evidence for the benefits, the health benefits of patients feeling heard and being heard as the sort of as holistic people with multiple needs. So I was just thinking it's quite interesting, isn't it? Because you could sort of, I expect you could build an argument that there's at least some grounds to think that health systems would be more efficient at meeting some of these other needs if they were constructed in such a way that that epistemic injustice within them was minimized. So I think that interplay is really interesting. But yeah, thank you.
Thank you.
Thank you both. Do we have any more questions? Again, Anastasia, go on.
Yes, if possible. One more question got burned in my head. Can there be any connection between implicational injustice and overdiagnosis?
So what do you think is the relationship between implicational injustice and overdiagnosis? Overdiagnosis of psychiatric disorders, especially.
Yeah, like, oh, she has this, she mentioned this, she has depression, but maybe she doesn't. No, like, And no, that in implicational injustice, if I understood correctly, that psychiatrist believes himself more, like that he knows, he has got this elitarian knowledge, and the simple patient doesn't know anything about psychiatry, so doctor knows better. So can this somehow lead to overdiagnosis?
Yeah, thank you. So when psychiatrists make mental disorder diagnosis, after giving mental disorder diagnosis, patient's utterance is viewed from the pathology, psychopathology. So in that case, patient's utterance is not considered speech act of testimony, but exhibiting symptoms. So if the mindset of psychiatrists has changed based on that mental disorder diagnosis, giving mental disorder diagnosis to patients, it can be a cause of implicational injustice, as well as it can cause testimonial injustice, because patient's utterance is considered as a symptom. The content of patient's utterance is ignored or not trusted. So in that sense, overdiagnosis of mental disorder is related to epistemic injustice.
Okay, thanks. I have a short but like a general question. As I said, I think you give a very good case in defending this special type of epistemic injustice, implicational injustice, and you give good examples of how it develops in the communication between a doctor and a patient. But what would you say are good ways to remedy this kind of injustice being inflicted on the patient? What do you think are the best ways towards amending this kind of a problem or injustice?
So
I mean, very general question.
Yeah, thank you very much. So I have mentioned case where the physician think that the patient says irrelevant things. In that situation, the physician is very irritated by patients saying irrelevant things. And this irritation is a chance to enter the life world of patients, because there is communication failure, communication gap. And that's why the physician feel irritated. And in that time point, not rejecting patient's utterance as irrelevant, physician can delve into what the relevance the utterance of patients has. It can the chance to change the situation, I think.
Yeah. Okay, I understand. But do you think that there are like limits to understanding the patient, his life world, so to speak, like the problems of radical empathy? Can you empathize to some? You can empathize to some extent, but to the whole extent, I guess, with somebody's psychotic episodes, delusions, and so on. There are some experiences that seem to be beyond our empathy or comprehension. Perhaps it could be a problem.
So, so this notion of implicational injustice is especially applicable to patients with chronic physical illness and some forms of milder forms of mental disorders. But as you mentioned, in a patient with psychotic symptoms, it is often difficult to what the patient really want to say. And there may be no implicatures in it.
But certainly, this would help physicians and doctors work on their skills of listening better and trying to figure out what are the implications of utterances of patients. So I think it's a very useful concept to have in medicine and psychiatry in general. Okay, thank you. Do we have any more questions or comments? Follow-ups? If not, I would like to thank Eisuke again for this very interesting and excellent presentation today. Okay, that's all. Hope we'll see you soon here again on our seminar and perhaps give another lecture. So the next seminar is on 12th of November, and I hope to see everybody and more people again. Thank you all for joining in and for giving questions and comments and participating in the discussion.
Thank you very much.
Thank you. Okay, see you all.